Hi everyone.
Hello.
How are you doing? You doing-
I'm doing well. Hanging in there. Yourself?
Same thing. Have have all these emotions now. It makes things harder.
Does it?
It
Hey,
yeah, I think I have questions that we can get into about this and
Yeah. Yeah, we
um
don't we don't want a spoiler alert or anything. It sounds like
but
that could be a good springboard for discussion.
right, but we could just get right into it. But still it's a little bit early.
Yeah.
Bill, I wanna interview you and we hadn't I hadn't seen you in a long time, so I'm
all
just
right.
gonna email you after this. I'm just letting you
Okay,
know
that's great. That'd be great. Okay,
about the
sure.
cognitive stuff really that you had spoken
Okay,
about.
okay,
Cool.
You
sure.
guys know each
Cool.
other?
Yeah,
Through
we've
this,
talked about, yeah, sure. Yeah.
I did not know that. Good to see you, Bill.
Good to see you too.
so thank you, Don, for doing this
Yes,
meeting
thank you.
in person. Um, so
Thank you for
this
having
is
me.
we can start with whatever you want to share and then have a lot of discussion, hopefully. So, thank you everyone for coming. This is the Building Brain Awareness talk series. The goal of the talk series is to get into discussion about brain injury related things, and this topic is alexithymia with brain injury. Dr. Dawn Newman is going to present, and she's presented before. Dawn, what do you think of the term emotional blindness?
What do you think of the term?
I don't like it. I don't like it,
You
but
don't
I'm
like
not
it?
sure.
Okay. Yeah. Okay. Why?
I think blindness suggests something that is a passive inability versus like if you're blind, you just can't see. But with building emotional awareness takes a lot of work and it's hard and it takes energy that's emotional. So yeah.
I have seen the term used before. I tend to throw around a lot of different terms. Emotional insight. I've heard emotional blindness. I guess that does give it, I don't know, some sort of as if you have an inability to see.
Right. If you're blind, that's it. I mean, I don't know, maybe some people can work on their vision, but um I had heard it recently and it's short and easy to say, but I think it leaves certain things out. The
Yeah.
blind.
Is
Yeah.
is this is this similar to like a person that kind of withdraws emotionally when faced with whatever stresses? That's their coping mechanism, or is this something more? I flat out don't see how other people respond, or I'm unable to.
Well, what you just said about the coping mechanism, I think about it a lot more like that now as I
Mhm.
try to deal with other things and emotions happen. I realize, oh, when I had alexithymia, it was like a safety or yeah, like a coping mechanism to not have to deal with any emotions because of all the other brain injury problems, I guess. And I do think I injured right side and emotional processing in a lot of ways. Hi, Maz, you have a question?
Yeah, I'm getting a bit confused about this. Um, I had an experience of not feeling any emotions myself. I could see what others were feeling, but I wasn't experiencing my own emotions to things like what Dan was just saying, where there's too much going on. I believe what was happening there, there was just no information because there was so much information
hmm hmm
that my brain couldn't process. So
Yep.
there was actually a dulled or non emotional response because I was in survival mode. So for that, that's different than not being able to attend to other people's emotions. I could see other people's emotions, but I couldn't respond to them in a way that I
Mhm.
did before the accident. So just because I couldn't respond to them doesn't mean I wasn't under, having a certain appreciation of knowing I was in touch with, somewhat of how I was before my injury. And so I had an appreciation of how I would have responded before, but there was no capability of doing that. Lost
Yeah.
language skills, lost ability to understand auditorily. Um, and so that's been a building process. If you can't, process the auditory information and you can't respond quick enough, then the moment's gone. And then if you try to respond, then that confuses people and they get all kinds of ideas about you. It just goes on and on and on. So is this about us not understanding others, or is it about us actually going from a point of survival that doesn't incorporate feeling in the sense that we felt before, and then having to get enough abilities to then get out of the survival mode to start to feel our own
That's it.
emotions.
Yeah. Thank you for stating that because that's a good some of the times I talk about brain injury is loss of capacity, and sometimes there's also a layering of problems that what you're describing is like a really fine, almost like teasing out of how part of this can be injury to that, and part of this can be because of all the other dominant brain injury problems. Your body's not even able to tap into that, but you still had the capacity, it sounds like. And I also want to share that in the first 7 years, I wasn't where I was at now. I was like really like there's no emotions here and there's so much internally to deal with.
I was just gonna say, like, these are great points of conversation that I think some of I prepared a little bit of a presentation that may touch upon these things. And just to make sure everybody's on the same page, maybe we should, would it be okay if we kind of jumped into the presentation? I feel like we
Yeah.
should have ditched the presentation, just on a whole Q&A.
Well, there's not
But
really, yeah, there's not really structure because everyone that I invited, I was like, let's talk about this kind of stuff. So with that, strange introduction that is actually good. Let's get into Don's presentation or Dr. Newman's presentation about alexithymia. Thanks, Dr. Newman, for doing this.
absolutely, it's my pleasure. And I think we're all here because we have that knowledge, or this understanding or belief that things are a constant evolution after brain injury, that things are not static, that we are always changing and improving, and that there is plasticity in the brain, and that we can learn to, rebuild some of those connections that have been weakened or been impacted by the brain injury, as well as some of those more kind of secondary effects. And I think that this is a perfect way to kind of launch into the presentation, because I do want to frame this presentation around a topic of resiliency. And so, but before I jump into that, I think several people on this call know who I am, other people don't. So just briefly, and I just want to say thanks to Daniel, Dr. Avasar, for inviting me to present again to you guys. He always has a great, thoughtful group of people that ask amazing questions and change the way I think and understand and pursue this topic. But I'm Dawn Newman, and I am a research scientist and manager of research, brain injury research at Hackensack Meridian, JFK Johnson Rehabilitation Institute, and that is located in Edison, New Jersey. I have a PhD in rehabilitation science, and before coming to JFK Johnson, I had spent 14 years of my career at Indiana University in the School of Medicine there, in physical medicine and rehabilitation. So all of my research is on helping people who have experienced a traumatic brain injury, and trying to understand factors that contribute um, to challenges with managing and controlling emotions, often looking at factors of social cognition, and then looking at those factors and developing interventions and training programs to help come up with programs that can then improve those skill sets and ultimately have an impact on emotion regulation and changes in behavior. Brief disclosures, this work, I've been very fortunate to have this work funded by numerous federal funding agencies. So just wanted to give a shout out there. So, like I said, I want to start this presentation off by talking about resiliency because I've been really starting to think about how alexithymia is factors into one's resiliency or how resilient one is after their brain injury. And so the definition of resiliency, according to the APA Dictionary of Psychology, is the process and outcome of successfully adapting to difficult or challenging life experiences, especially through mental, emotional, and behavioral flexibility and adjustment to external and internal demands. So, no need for people with brain injury to have resiliency skills, right? Um, so when we think about the adversity after brain injury, people with brain injury are no strangers to adversity for sure. And there's different types, and I think about adversity, there's different types. I think about the types of the interpersonal challenges that people with brain injury are often faced with, whether or not it's a direct result of the brain injury or if it's a secondary factor. But challenges with cognition, emotions, behaviors, communication, physical, sensory, pain, sleep, fatigue, health, comorbidities, self-efficacy, dependence for certain people. And this is not an exhaustive list. I don't have a slide big enough. But then there's also the interpersonal impacts, challenges that people with brain injury are facing. And this could be secondary to the intrapersonal things, but strain in their relationship, which may often cause their social support networks to get smaller, feelings of isolation, loneliness, losing one's own social or self-identity, changes in role changes, and then a concept that I kind of learned from Daniel about more about when interacting with other people, this common issue of being misunderstood by other people and people not understanding the brain injury and the experience. And then,
Thanks for saying that. And Don, can you just define intra and interpersonal?
oh, thanks. Yes. So intra being within yourself. So these are the challenges that you're experiencing as yourself, you as an individual. So the challenges that Daniel experiences. Interpersonal are those challenges that's going to happen when there's other people involved. So between yourself and me. So we may be having a conversation. So it's between the self and others. And then there's community and environmental level challenges, right? So these bigger things in terms of, again, this could be this cascade of effect in terms of impacting, job retention, loss, disruption, instability, or whether you're going to school, financial burdens, and just kind of all of those needs that a brain injury puts on individuals that requires one to navigate really complex systems for very unique resources. For instance, accessing healthcare or what have you, creates all of these unique challenges and adversity following a TBI, requiring stronger resiliency for better outcomes. But unfortunately, when you go back to that definition of resiliency, adapting to challenging life experiences, that there's this expectation that the foundation of resiliency is having that mental, emotional, behavioral flexibility. So strength there. So the very thing that's needed for resiliency are inherently impacted by a brain injury. Emily Nalder, who is a colleague of mine out of Canada, she and her colleagues created a model of resiliency following traumatic brain injury. And it's not my goal to get into this whole model here. Obviously, there's various factors that she's putting into this model that influences resiliency and then those protective factors. But where I really want to focus the attention is being a key factor in this model of resiliency is box A that talks about these self-regulatory processes. And so, what are self-regulatory processes? Um, Self-regulation, it's basically a construct in which individuals are evaluating the situation that they're in, and then managing or controlling their emotional reactions, their thought processes, and their behavioral responses to a situation. But like I said, these are the very things, while these are things that are protective, that facilitate res a resiliency and a better outcome, are things that are challenging for people with brain injury. And so we could think about this not just from an impairment standpoint, but we think about this from a standpoint of what can we do to intervene to strengthen these skills, these self-regulation skills. And so when I think about that, I think about this process model of emotion regulation that was created by James Gross, who is a psychologist at the University of Stanford. Has anybody ever heard of the process model of emotion regulation? Well, maybe you
I have.
haven't. Oh,
Yeah.
hey, that's awesome. That's cool. Great, Bill. It's one of the models that actually has informed a lot of my research and what I focus on. And so when it comes to so what they put forth, James Gross and his colleagues, basically for you encounter a situation, and this situation could be, let's say, going to, it could be an external situation like going to the mall to go shopping, and I have no idea why I brought up that because I never go to a mall and I hate shopping. I guess because that would be a trigger for me. Or it could be an internal situation. It could be your own thought about something, a concern, a worry, whatever it is. So you have a situation that's going to ultimately lead to an emotional response. But once you have a situation, you have to pay attention to certain aspects about that situation. You're going to then appraise that situation or evaluate that situation. And then you are going to have a response. So that response you're going to have is going to include physiological changes, changes in your emotional state, and how you are going to react or how you're going to behave in response to that particular situation. And what James Gross and his colleagues said is that this is a process of how you go from a particular situation to an emotional and behavioral response, and talks about how there's antecedents where you can, along this way, you could either intervene to regulate your emotions like preventatively before that response happens, all along the way. So if you anticipate a situation, you could either avoid the situation or you could mentally prepare yourself for the situation. Um, you could make changes to what you pay attention to about the situation, and then you can make changes to how you appraise or how you evaluate that situation. And that can help you regulate how you're going to respond to that situation. And then interestingly, as part of this model, our ultimate emotional response becomes the situation. That becomes an internal situation. And um, it is that acknowledgement that our emotional response becomes a situation that we then need to pay attention to and appraise in order to make a conscious decision to regulate that emotional response. So we can have an emotional response that we then, through our emotional awareness, attention, and appraisal, are in a position that we can then regulate what that response is. But it does require us to be aware. If we have this emotional response, but we don't know what it is, then that is going to be much more challenging to regulate. So, which brings me to talking about emotional awareness and alexithymia. So, we've thrown around this term. Lots of you guys joined this for a reason. Some of you are probably already aware of what the term is. Some of you maybe not, or maybe a review will be helpful. But alexithymia is a deficit. an emotional processing deficit. So if you have alexithymia, it's made up of a variety of characteristics or constructs. So someone with alexithymia could pertain to not necessarily knowing or recognizing when you're having an emotional response. It could pertain to, you have an emotional response, you just don't really know what it is that you're feeling. So you can have challenges with labeling or describing those emotions, or being able to use specific labels to describe what it is you're feeling. You may have difficulties distinguishing one emotion from another. So maybe you're not quite sure if you're feeling angry or sad or afraid, or maybe a combination of all of those things. Or you may have difficulty thinking about emotions in general. So you go about your life thinking about the facts or the information, the knowledge, but not necessarily how you feel about those things or how other people feel about those things. And then people with alexithymia can also, um, with regards to a lot, when we're having an emotional response, it's accompanied by different changes in our body, physiological changes, sensations that are a good indicator of when we're having an emotional response. But if you have alexithymia, it some people may not pay attention to those things at all, or some people may pay attention to those things and misunderstand what they are and not realize that they're connected with an emotion. So, I think this kind of question came up earlier about what is this? And alexithymia is not brain injury specific. And so there's three different ways in which alexithymia can manifest, or reasons that alexithymia could arise. So one of them is through the way we're raised as children, how we're socialized. So if you were brought up in a family where you are taught to and to talk about emotions, and that that's okay and it's not taboo, then you're going to be less likely to have to struggle with these things. However, some people may be raised in a family where it's taboo to talk about emotions, or it's not manly, or to buck up, and so that those types of things are not condoned, and so therefore that could lead somebody to have characteristics of alexithymia. The other reason for developing characteristics of alexithymia is the psychological trauma. And I think that was brought up, where becomes more of an initial coping mechanism where we are exposed to some psychological traumatic event where our minds, our bodies can't handle, um, the emotion might be too much to handle at a particular time. So we just disconnect from any emotional response, and that becomes some sort of coping mechanism. But prolonged coping, that type of approach in a prolonged circumstance is actually going to be more harmful than good. Initially, it has to be something that is more transient. And then organically, meaning that this is from whether it's having a traumatic brain injury, some event is causing your brain, and the parts of the brain that are involved with processing emotions to be disrupted and making it more challenging. When we're thinking about somebody who has a brain injury who has components of alexithymia, we really don't know one way or the other if this is something. I mean, maybe you may have some idea if, from your own perspective, is this something that I've had my whole life? Was I raised this way? Or is this something that maybe you had it the whole time, but maybe it got even worse after your brain injury, or maybe this is something new after your brain injury. And maybe it's some combination of, how you may have experienced the brain injury. So is it a combination of trauma and neurological, et cetera? Um, so I do want to point out that this is something that's to normalize alexithymia. So while it can exist out there in the general population, it tends to be more common in people with traumatic brain injury. We don't necessarily know if it's due, again, to the damage to the brain that's disrupting those areas of the brain that's involved in processing emotions, or if maybe people who have alexithymia were more prone to situations that put them that in situations that ultimately resulted in a TBI. There is a huge range based on the literature, and this really depends on the population where people were gathering their data from. But what I like to say is that even at the absolutely lowest level of 15% of people with traumatic brain injury, given the frequency, the common occurrence of brain injury each year, that means that at least 10 million people a year who incur TBI are going to have issues with alexithymia, which is a huge number of people. So it is something that is to be normalized, and it's important to understand. When I think about that other slide I showed you, those are like the characteristics, or like kind of the descriptions of alexithymia, but what does it actually look like? And so I put this slide up because these are the common things that I've heard people say who have alexithymia. And I just want to take a minute to ask if anybody has ever said these things or heard other people say any one of these things.
Oh yeah. Yes.
Oh,
Which
yeah.
one resonates with you, Bill?
Um, it's a kind of a combination of several of them. One is I'm not really certain what I'm feeling, but and so it must be bad kind of thing, that kind of sensation, or either that or I'm numb,
Mm,
and the more I'm pushed on how it is I'm feeling, then I kind of revert to pulling inside, which is a psychological response, I guess. And and it's like I don't know. Yeah, so I always follow. I'm just angry. That's my default, I guess, descriptor. So I'm just mad, and
hmm
and and probably my behavior shows I'm upset. A lot.
Yes. Yep.
Mm.
Okay. So yeah, you hit a good number of them.
Thank you
Um,
for sharing that, Bill. And one question before we move to the next person who has a question. You said pull inside. What does that mean?
Um, well, I feel I'm whatever I'm feeling is unpleasant. I can't really describe what it is. And so now I'm afraid I'm going to, vent on somebody else. And so basically I just don't interact, or I withdraw, which is not great in a marriage, but I withdraw rather than trying to discuss what it is I'm feeling and maybe get some help as to why I'm feeling that way. But I just had trouble again. What is the emotion? And I seem to default to it must be a threat, that
Right.
mm.
I think
I have,
that that
I have some TBI that kind of kicks in with that as well. So, I mean, some PTSD. So,
mm,
mm.
adding that withdrawal, almost conscious decision to withdraw because of this situation, I think is really helpful because the outside world uses the word behavior, and I don't think they understand what we're dealing with that results in the behavior. So thank you, Bill. Liv, you have a question?
Yeah, I just wanted to respond. So I think that prior to my brain injury, I was numbing in general. So I didn't even know how to feel what I was feeling, but I didn't know that I wasn't feeling things, I guess. I thought that I was just supposed to move through the world. Um, and just move through it. And I think emotions were something that were just really like unbeknownst to me. And then post brain injury, I just felt myself feeling angry all the time. And so a lot of that I think has to do with a not being able to numb anymore, whether it be through, lots and lots of other kind of mechanisms, I guess. But now it's this constant sort of facing the reality of and not knowing how to navigate this new reality.
yeah. Yeah. And thank you for sharing that. And I think, it's interesting. So anger is a really, really common thing with this. And trying to think if I'm when I get further in the presentation if I'll address this or not, but one of the things that we talk about, so I'm going to be telling you, I'm ultimately going to be getting there, how we developed a training program to help improve emotional awareness and reduce alexithymia. But one of the things that I think is common with anger is it's so intense, right? And the physiological sensations that are there, they are so overwhelming and daunting. And because it is such a big emotion, um, all the way around, it tends to make it hard to see anything else, even though there are many other things that are typically there. And I think the anger is normal and it's common, but I think the way to get past that, well, some of the ways of getting past the anger are to work through the anger is to acknowledge that there are other emotions that are there that also need to be dealt with that are cascading into that anger. Um, but they're much more challenging to experience.
Thanks, Don, for addressing the anger aspect. And Liv, I just want to ask a question about what you said because you were talking about the other stuff that's there in the new situation with brain injury versus the numbness from the past. And can you explain a little bit about what you meant by that, if that makes sense?
Yeah, sure. So prior to brain injury, I was high performing. And so I used to numb through, many, many ways, right? Whether it was, well, just a series of addictions, whether it were travel or substances or drink or whatever. And so, I think that because I never was able to really understand what my emotions were outside, I think I always knew that I had anger kind of issues, but I was basically numbing to get to this place where I could like thrive. And I think it also had to do, there might be some masking abilities as well. And I think actually one of the things that I did ask to Dawn in the chat was about burnout and alexithymia specifically, because I'm curious to see if there's any research on that. We can get to that later. But the point is that at this point, I don't really know, like, I'm just feeling one like very, very common and heavy um emotion, because again it's at this point it's figuring out how to navigate life, because my cognition is a little bit frayed, or needs to be sort of worked on, and I don't know where to go from here, right?
Yeah.
Does that make sense? Yeah.
Yeah, as a person that it took me 7 years to rebuild my cognition, I can share that I agree and share, or I know what you're talking about exactly, because when your thinking is not happening on so many levels, um, that's a core brain injury problem that changes reality every moment. Um, Maz, you have a statement or
Yeah, there were 3 points.
three
Um,
points?
One, I wanted to acknowledge you talking about you just mentioning others call it behavior when there's so much going on underneath the hood. Um, Others call it behavior because that's what they see. Um, we may be seeing what they see, but we also have other things going on that they don't see. And so they put it in categories perhaps that are not appropriate. And on that note of what I don't have the screen up, so I can't say his name, but the guy that spoke said that he blamed himself for his anger. I call it functional anger. I've recognized myself that in order for me to get my brain to get information, to respond to information, it takes an anger that what anger does is it releases cortisol, which then release lipids. The lipids can then go to the body organs so that our brain can get more um, glucose, which is needs in order to get, you know, operations in the brain. And in order for us to try to do anything with our deficits, it takes that kind of emotional escalation for us to get to the information, for us to respond or do anything. That I've recognized that in myself. Blaming ourselves for the anger is not beneficial to us. It doesn't put us in a place of empowerment or ability to then recognize what's actually going on and find ways to build. And then there was one other thing, and I don't remember what that was, but those were the two things that I really wanted to say.
Thank you, Moz. Julie, I see your microphone came off or your mute. Were you going to say something? You know, emotions are there for a reason to motivate us to do things, and that's why one of the arguments for why emotions are important and recognizing they're there. But yeah, as long as they are not interfering, I mean, that's the part where it becomes this balance that you need to have put in place of too much escalation is going to interfere with the prefrontal cortex functioning, fully functioning, and, you know, thought out decision making, et cetera. So I think that there's a discussion, that you could have. Is just like, I think there's a certain amount that's necessary, but then there's always too much. So, um, but anyway, yeah, should I, continue?
Yeah, I think continue. You have this part about treatment stuff, right?
Yes, I do.
Yeah.
Please
Yes.
continue.
Thank you.
And I have like
Okay.
100 questions. I'll
I
just keep them in my head. I'll keep them in my head for another time or maybe at the end.
yeah, I was gonna make it super short and then I felt really weird about doing that. And then, I don't know. Anyway,
It's okay. It's okay. It is what it is, right? And so, yeah, please
yep,
continue.
just rolling with it. So, I think I may have mentioned, well, some of this is repeats from prior presentations I've done for your group, Daniel. But anyway, one of the things that we have found out through research is that, alexithymia is something that is commonly associated with these things, these worse outcomes. So I have all of this information on the screen. There's been publications to show it's related to worse regulation of emotions. We talked about coping and that avoidant coping, whether it's, substances, travel, whatever it is, that avoidant coping, has been associated with lower resilience, anxiety, depression, PTSD, anger, aggression, hostility, lower life satisfaction, suicide ideation, loneliness, lower empathy. Going back to the burnout, interestingly, so it's been observed in caregiver burnout. So if somebody has alexithymia, the person, their care partner, has been shown to have more burnout. Um, I'm very interested. I wanted to go back when we get a chance to the burnout question, like self burnout for the person who has alexithymia. It's also been associated with worse relationship quality, somatization, and pain. Anything, I mean, seems surprising here.
Well, first of all, can you define the burnout and with the somatization and pain, what does somatization mean? And how do you know that those things aren't happening concurrently because of a different underlying issue?
Good question. So yeah, I think with the burnout, it's more of I am I knew you were going to ask that, and like am the worst to define things on the spot. It's just like one of those things. Like I know what it is, but putting words to it.
Well,
Um,
Liv have a statement as per her question of what does it mean? Because I had cognitive burnout and I had the fatigue burnout, but what's the emotional version of that? Or
Well, for me, I think it's sort of the not. I think it comes with the anger, right? So it's like that's the cycle of trying to do something new to kind of aid in your development or your self like actualization with your new brain or your new sort of phenotype, so to speak. And basically like not quite knowing where to go. And so you wind, and so you kind of cycle through these periods of anger. You cycle through, and this is again my personal experience. So please, like, this is just me, but a lot of what I'm now recognizing 5 years in is that I've had these moments where I'm like trying to do and go and or not, and not even in a way that is, that is like supposedly debilitating. It's just trying to move on with life and trying to figure out that new sense of what life is for me. And I burn out, like, I just burn out, and I can burn out for days, I can burn out for weeks, and recently it's felt like I've been burned out for months.
Is
So
is the burnout a fatigue of brain injury kind of burnout, or is it more to the emotion or the whole situation?
I think it's all of it. But I will say that there's a additional kind of, when I think about, I moved recently, which is another layer because it means new doctors, new this, new everything. So anything is just, it's sort of amplified. And I just find myself getting more migraines, feeling like I can't do things. And so that's sort of where it stands. Now this is again related to a life transition, so that may be a totally different piece, but that's kind of where I was thinking when it came to burnout. And also I'm doing a lot with like like I'm seeing a lot of sort of like potential like relationship to masking as it relates to autism and ADHD and other types of neurodivergence. And I'm wondering if there are any ties to that, which is why I asked the question about research specifically.
Yeah, it almost sounds like there's just like it's exhaustion. It's like you're on E, you're running on E, and just and it just sounds like it's just from all of the extra, everything takes so much more energy to
Yep.
do and fit in. And
Can I ask
See,
you a question?
oh,
Can I ask
hey
you a
Randy.
question? Hi, Dan.
Hey,
Dawn, you're familiar with EMDR?
yes, I mean, not
Um,
personally. I only know
no, no,
of it.
no, but
I've never seen it.
you know what EMDR is.
Yeah.
Um,
Maybe for the rest of the folks, but I forgot what it stands for. Eye movement
eye
dis
movement desensitization and
desensitization.
reprocessing.
Thank you.
I'm wondering, what do you think about the role of EMDR in terms of helping to remediate any of these, what are essentially are symptomologies of alexithymia?
So I don't know the science behind EMDR. I know a lot of people believe very strongly in it. I do, so I will admit I don't know the science behind it, so I don't
Okay.
know. But I do know that people do use it, and some people I think that there's supposed to be evidence behind it. I have not actually looked in terms of the evidence. I would like to see the research support behind it. I will say that there are people that I've worked with alexithymia that say they have done EMDR and have not found it helpful for their alexithymia specifically.
Have not?
Yeah. But that doesn't mean that that's one person. That's one
Yeah,
person.
yeah. I just
well,
Mhm.
finished a session just before I came on here. I've been doing this for several months.
Mm.
What I have found is when I look at this list of symptoms that you have of alexithymia, I'm not even sure if diminish is the way of putting it, but it somehow seems like it or diminishes the charge, the emotional charge, if you will, that goes along with these symptoms. When I
The
say goes
EMDR.
along, yeah, I think
Mm.
the
Interesting.
yeah, it's I mean, it's not that I'm looking at this list of symptoms and much of it applies to me as well.
Yeah.
It's not that that it goes away, but something is, it's almost as though there's a distance put between myself and the memories that lead to the exasperation of these symptoms.
Mm-hmm.
Does that
Right. So
make
I think
sense to,
it's
does
a
that make
different,
sense?
yeah, it does. I think it's just a different approach. So what I'm saying here on this slide is that we know that alexithymia is related to these things. In my From what I know and from what I am doing, my approach is to say let's treat the alexithymia to hopefully mitigate or reduce the charge or help with these consequences. You're saying that you're doing it through a different method.
One thing I can share about Randy, because I've known Randy for years, and when we met, we were both in the being numb about everything
Mhm.
stage, and I think Randy is beginning to gain access to the emotions. There's a lot of, I called it the gears of emotions not working, not happening. I know Debbie is here. Her and I have discussed versions of that. And I think Randy's almost getting the effect of the EMDR to cause the exercising of those gears to happen in a way that he's never experienced because we talk almost every week. So, just to share a contrast, there's someone else here, Mandy, that I put out a podcast with, and Mandy's a neurology nurse practitioner, and she has a lot of awareness of the stuff as she injured and rebuilt it. Mandy used EMDR to deal with her PTSD, and she didn't have, as far as I can tell, this emotional inability that we're talking about or emotional numbness. Those processes are happening in her. That's what EMDR is built for. When those processes don't work because of whatever reason, like brain injury, I think that EMDR won't work unless you can have the emotions happen. Ability for the
Say this
person.
again, Dan. Say that again, Dan.
It's gonna be hard to have EMDR stands for what?
Eye
Mm,
movement
eye movement.
desensitization
I'm moving.
reprocessing.
Okay, so the desensitization of what? It's a desensitization and reprocessing of emotions that happen. You have memories of the emotional events. If you didn't experience the event emotionally, it's a completely different brain. Maybe the emotions were there, but you were not aware of them. But you need to have like had those emotional gears happening. If you're not experiencing the emotions, it's not going to happen. It's going to you need to have the emotions happen for the EMDR to work is what I'm saying. Um
I do want to interject there because I don't think any one of us are probably experts on EMDR, and I don't have the ability to do that. And I think we might be getting a little too far afield from talking about going through. I want to be able to get through this, and so people can kind of because I can't comment on the EMDR or its
right.
evidence.
I
Just
speak based on
Dawn,
opinion
is
of
there
brain injury. Yeah.
anything that actually significantly alleviates, heals any of the alexithymia?
yeah, I was going to get into the treatment that we do for it and show you the evidence behind that.
Yeah, let's continue then in that.
Okay.
Think the other thing I just wanted to emphasize is that we've also done research that um, not only shows, so that last slide was both mainly talking about research that shows that alexithymia is related to these things. But in those studies, there's no way to know if alexithymia, so let me go back for a second. In these studies, there was no way to know whether alexithymia is leading to these things or the other way around. Are these things is depression leading to alexithymia or is alexithymia leading to depression?
Hmm.
Or, vice versa. So, meaning that the research, there's no way to determine the direction.
Or the
Where is
brain injury is leading to all these things because we have each person here has a list of internal problems that they're dealing with from the brain
right?
injury.
And we don't know the impact of that, right, as well.
Right. But
But
that
this
has to be on
research,
the table.
yeah. Now, this study that we did, we actually looked at this research from a longitudinal perspective where we looked at alexithymia 1 year post brain injury. And we found that if the more higher levels of alexithymia somebody has at 1 year post brain injury, that specifically above and beyond other factors predicted um, it, the following year worse levels of anxiety, depression, emotion dysregulation, lower resilience, suicidal ideation, and aggression. So it was the first time that we were able to show from a research standpoint that that alexithymia is literally impacting the future outcome of something. And so we can say that from a directional standpoint. So I think it just drives home the point that alexithymia is a factor that needs to be targeted and addressed. I do want to just bring it back to what this looks like. So what does that actually mean? Um, for regulating, like going back to that James Gross's process model of emotion regulation. And if we're going to look at that mechanism, we're going to say, well, we have an emotional response, and then that emotional response becomes a situation. And in order for us to regulate that emotional response, that means we have to have awareness in order to attend and appraise it to regulate it. If you have alexithymia, which means you don't have that emotional awareness, that is going to mean that you're not going to be able to then regulate that emotional response. So when I think about it in terms of resilience, we think about we have a stressful event, we have an emotional response. If we have emotional awareness versus we have alexithymia, in one case we have emotional awareness, the other case we have alexithymia. If we have emotional awareness, we have at least the foundation needed to process those emotions and regulate those emotions. I'm not saying it's the end all be all, but you have the basic tools that you would need to do that. Um, and then hopefully you process, you regulate those emotions, and you ultimately bounce back from that particular stressful event. Whereas alternatively, if you have alexithymia, it's you're not aware of that emotional response. It's going to lead to a dysregulated emotional response. And it's going to prolong and become chronic and ultimately evolve into psychological distress. That is the theory behind it. So that is why we developed the training program for alexithymia, specifically targeting it. And so what the training involves, it's 8 sessions, and the sessions are range from 60 to 90 minutes long. It is delivered by a person who is trained in the intervention, um, along with the patient. So it is delivered in a one-on-one environment. I have not done it in a group environment, although other people have asked me about that. I have not done that. Mixed feelings about it. In the research that we've done it both in person and remotely, successfully. And the intervention includes when we deliver it. So many of you here may have experienced what traditional talk therapy is like, or what have you. It is not therapy. What I would want to say, it is not therapy. It is a training program. So it consists of lessons that are delivered and portrayed on a PowerPoint presentation, just like I'm showing you right now. And then, so it's very psychoeducational oriented and meant to be very interactive.
On those
Yeah,
lessons in can you say in brief, like what are those lessons of?
a little bit. I don't necessarily have too much time to get into it. I'll show a little bit,
All right,
and
yeah.
then you guys we can maybe if there's more questions. Um, but yeah, I'll get a little bit into it. And then when we also provide exercises for people to take home so that they can practice the lessons that they've learned. And then we have a binder that we provide to the participant. I should change that to participant, not subject. But so getting a little bit into this, so there are 2 types of sessions of the 8 lessons. So lessons 1 through 4 are very, very psychoeducation oriented, where we are really teaching, going over the value and the importance of getting to know your emotions and getting in touch with your emotions, whether it's just for managing your emotions, for your relationships, for a healthier lifestyle, and not getting into those poor coping skills or avoiding coping skills. for decision making, motivation, all kinds of things. We get into emotional vocabulary, um, for being able to identify, have access to labels or specific emotions. We talk about differentiating one emotion from another. We talk about anger, and identifying emotions beyond anger. We do some mindfulness exercises to increase attention to those physiological symptoms. So we talk about emotional arousal and what emotional arousal is and how we pay attention to emotional arousal. And when we recognize there's an emotional response, and then how to link those symptoms of emotion or signals of emotional arousal with labels, emotional labels. That's mostly lessons 1 through 4, and then 5 through 8 are very an opportunity to practice the skills, all of the skills that were taught in lessons 1 through 4. We show people emotionally evocative video scenarios from a first person perspective, and then we have people process through what their emotional response would be. The objective of the training program, this is actually a slide from the training program. The intervention last is called has been BEST, Building Emotional Self-Awareness Teletherapy. Anyway, that's what I'm saying. BEST builds a foundation of fundamental skills essentially needed to work through unpleasant feelings and emotional distress, regulating emotions, coping and resilience, and relationships. So, however, we talk about how we don't train any one of these things. We just talk about how we are building the foundation of the skills needed for these things to happen. But actually, I just realized I had this beautiful slide here. I do that all the time. So the training itself is involved. So we teach people, like I said, the benefits of recognizing and labeling emotions. We teach them the emotional vocabulary, specific emotions, name it to tame it type thing. I don't know if anybody's ever heard that before, the name it to tame it. But that's true. You put a label, there's research to show that if you are emotionally upset, that's very like anger, like very limbic lizard brain type thing where its amygdala is reacting. If you are naming things, that means you're engaging the prefrontal cortex, so that helps to put on the brakes and downregulate some of the unpleasant sensations when we're experiencing an unpleasant emotion. Helps you to we go over lessons that teach people to discern their emotions from non-emotions and discern them from each other and discern them from anger, and then how to link sensations with labels. So we go over what are vague labels, like things like, how are you feeling? Bad, crummy, upset. Those are not specific emotions. We talk about what are specific emotions. We go through what emotions are and what emotions aren't. How emotions are surrounded by thoughts, actions, and physical sensations, and we often use them interchangeably with emotions, but they are not the same thing. And it's important to be aware of that. We talk about emotional arousal, and we talk about that interoceptive awareness, if you've ever heard of that. So what's going on, that sensation in our body, mindfulness to do that. We talk about physical sensations, what sensations like heart rate, perspiration, body tension, where we feel these things in our neck, our back, our arms, when we feel these things, paying attention to them and detecting them earlier, and understanding what our baseline emotional arousal is so that we could detect when it deviates from baseline, from when it's from your usual, and how to link them with emotional labels. So the training that we developed, as far as the evidence for it, so that was the training program, essentially a description of that. We have had a series of 3 studies so far. This is one, so reductions in alexithymia and emotion dysregulation after training emotional self-awareness following TBI, a phase 1 trial. Then we then renamed it to calling it TREAT, so training to reconnect with emotional awareness therapy. And that was a randomized controlled trial. And then we did most recently, this was published in December of 2025 when we renamed it again to Building Emotional Self-Awareness Teletherapy. And we did that in civilians and service members with mild traumatic brain injury. So just to kind of give you an idea and a glance of what we did. So here we have the three studies side by side, and it's looking at how they differed across trial design, the number of participants, the treatment dose, and the mechanism of delivery. What you'll notice is treatment dose is the same no matter what study was done. The very first study, it was a pilot study, and it was just we looked at people before, we evaluated their them before they went through training and then immediately after training and then a three month follow-up. Whereas study 2 was a randomized waitlist control trial, meaning that we randomized them either to when a participant would come in, we would say, okay, you're either getting the treatment right away or you're going to get the treatment, but it's going to be delayed. You're going to be put on a wait list. And then the most recent study again was where it's what we call a single arm. Everybody got the treatment right away, but we did evaluate people twice before they went through the training program. And then we ultimately looked at them post-training and then 3 month follow-up. As far as participants, the first study only had 17 people and it was moderate to severe TBI in civilians. The second study was 44 civilian participants with more moderate to severe TBI. And then study 3 was 40 participants, 20 of whom were civilian and 20 military service members. And the first 2 studies were in person, and then the last study was done remotely. So you might be wondering, what did we find after we did this treatment with our participants? And again, I put the study results out here for all 3 of the studies that we had. So for all of the studies, we looked at alexithymia, we looked at emotion labeling, we looked at emotion dysregulation, anxiety, depression, and anger. And essentially, what we saw, studies 1, 2, and 3, we saw significant improvements on alexithymia, emotional labeling, emotion dysregulation, and anxiety. When it came to depression, we saw significant improvements in the second study and the third study. It's not in the first study. It was a smaller number of subjects. The reason I just realized, the reason that there's double asterisks and single asterisks, it's not how significant it was. It was the double asterisk means that it was significant immediately post-treatment and then the follow-up period time as well. So showing that we're maintaining the effects that we initially created or saw after the intervention, I should say. We saw significant improvements on anger across all 3 studies. And then when we got to the third study, because this is mild TBI and it was military, we looked at resilience and post-traumatic stress, and we saw significant improvement in resilience and post-traumatic stress as well. These were other outcomes we evaluated on the side. They weren't part of the study itself, but we looked at something called ambivalence of emotional expression. We looked at emotional approach coping. We looked at the process model of emotion regulation. That was like that model that I was showing you earlier of how we regulate emotion. We looked at interoceptive awareness, was that ability to tune into those signals within our body. We looked at an overall measure called the neurobehavioral symptom inventory, and we also looked at loneliness and saw significant improvements on those as well. So this is exciting, but I think to drive home the point, it's like alexithymia is a common thing after brain injury. It's associated with our emotional functioning, resilience, and loneliness. It does appear to be something that's treatable even many years after brain injury. And when it is treated, it does seem to be associated with improvement in emotional functioning and resilience. But I will say, as exciting as this is, I do realize from a research standpoint, the samples are somewhat small and we need more rigorous designs. So we are working on more studies to continue to evaluate the efficacy of the intervention. I will say that I do have my hopes up, and that I think through one of these things that it makes me really happy is that this seems to be a training program that can be delivered in person or remote. So hopefully improving access in that capacity. The other thing is the people that provide the intervention don't have to be PhD level people. We've seen this delivered very successfully by people with the bachelor's degrees. So we are increasing the number of people that can deliver the intervention. Um, and then prevention, I'm hoping that, so what we're saying that earlier on, if my goal is hopefully that we could determine and detect alexithymia earlier on and treat it earlier on before psychological distress and other consequences get out of control and formulate. And then I do realize that this is not going to be the answer to everybody's um to all problems out there. So my hope is that if somebody has alexithymia and they do need psychotherapy, but because of the problems with alexithymia, um, and if you have alexithymia, it's harder to engage in therapy because of the lack of vocabulary or awareness. My hope is that we could do a precursor training to give people the tools they need to more actively engage in therapy and benefit from therapy. So with that, I will wrap it up and thank you for your time and attention.
Thanks, Don. I think it's really important that your data shows that this does help people, and I believe that it can help people. I was also thinking of when we started the statement I made about how emotions makes things harder. As a brief example, as I have learned how to have access to and have my feelings happen more now than ever before. In the first 7 years of my brain injury, I was not like that. The 2 points I wanted to make is when the emotions are really bubbling and it's not anger, it's the other painful emotions, doing something very basic like going shopping, or I don't remember what it was, doing really simple tasks became really hard. But in the first 7 years of my brain injury, the working on my brain injury problems was a task that's like an internal mountain, far greater than anything else. So that's why I'm saying the emotions make it harder to do the things. And when I didn't have access to the feelings, I think I could focus on emotional. The brain injury problem is 100%. Introception is a good word because I think everyone here has. The other thing I was going to say is I think your model is flawed because if you have an event and then the subsequent things, the event needs to include a list of the internal brain injury problems that we're introspectively aware of that are a long list for every brain injured person. So that model is without a brain injury. In that sense, is not completely fitting. Just want to say that, and you can respond. And then if anyone else has any other questions, does that make sense though? That it's
Are you talking about the process model of
yeah, the
emotion
process
regulation?
model assumes that there's an event and then we are responding to it. But what if the event is I'm double visioned, I have fatigue, the world doesn't
Oh,
feel
that's the internal.
right. So
So
there's a
when
lot of internal stuff happening.
yeah.
With my mind, I had depersonalization, derealization, as well as the symptoms that I was aware of. And then as I dealt with the symptoms in a
Mhm.
hierarchy, others came on more clear. So that's why I feel like that model is missing the brain injury problems.
Well, it's just I just want to address that though. And by the way, it's not my model. So anyway, I think it's interesting to
The
think.
model with which you have here, which is important
Yes.
for
What?
discussion because it
Oops.
is how
Yes.
people think about
So
things. Yeah.
yeah, this one, Daniel.
Mhm.
Yeah.
Yeah.
So what you're talking about, like the double vision, that would be an internal situation. See how the situation becomes something internal? So this is anything internally that you're dealing with your brain injury.
Right.
Or
But if the situation in the experiment or in life is, are you going to school? Are you getting out of bed? And my internal situation is, I have double vision. The world doesn't feel real. I have to get out of bed. and I don't have cognition, so brushing my teeth is going to take all my effort, then it's all five of those
Yep.
things need to be there for the attention and appraisal. Um,
Hmm.
Andy's a person here that I had this really good discussion with recently. Injury to the awareness of the brain injury, injury to the internal problems can happen. So it becomes seven of these things happening at once. So
Yeah.
then response maybe not a response that if I didn't have those other six internal things happening, it
Yeah.
changes
No, I think that's a fair
rules.
comment
Yeah.
because it's just everything's compounded. And so you're like all of these different things. I think that's a really fair point. It's never just one situation on its own.
The one example that worked with someone else was talking about the hungry and angry. And if you have to make a decision and you're hungry and you're angry because you're hungry, but you don't realize it, that hungry is just one internal thing. There's like 10 more crazy different ones with a brain injury. So that's,
Hmm. Hmm.
yeah,
Yeah.
but that's an unbrain injured example. Moz,
I recognize the dysregulation um, occurrence. I took all the psychotherapy that addresses that. I realized that our dysregulation with TBI is very different. Our dysregulation accompanies a fatigue, neural fatigue, in which the brain has no capacity whatsoever to rally itself to do any of the responses. And it's just the behavior appearance from other point of views looking at us. They think that we can. They think that we are that our dysregulation can be accommodated by these different methods and therapies. But if the brain is not capable because of a functional deficit of um, fatigue, in which neural fatigue, it's beyond dysregulation in the typical sense in which those in the mental health arena are addressing. And I think perhaps that is what Daniel is talking about. It's I know it's what I have experienced. I have
that's one of them. The
my
fatigue
father,
is one of the internal things, but there's
right,
also the problems too. And I have
exactly,
a
all the things you mentioned.
fatigue
Yeah,
talk. We're gonna have a fatigue talk November 10th with Jared Brown. He's presenting the outside view. I'm presenting I'm presenting what you just talked about basically because but that would be one factor, and you don't always have the fatigue, and the fatigue can escalate and change drastically. I know people talk about being really tired affecting your emotional regulation ability. This is a amplified version of that comes with brain injury.
I agree. Yeah, I just pointed out that one little specific thing that there's an incapacity physiologically in order
Hmm.
to do the steps that are required. And I'm well aware of what I was before and how I was able. And I'm I've over 40 years studied myself and tried to get to the bottom of all this. I've done every therapy possible. And I also know that a lot of interactivity can give you the dissolution of help when it's actually interactivity that's prompting the brain and not really actually affecting long-term uh, comprehension of in the real life situations.
So in
I'm done.
that, yeah, I think of that as a deeper view of the internal problems once you have with all the internal problems that come with each brain injury in each having brain injury for each person. Sorry. Dawn, do you want to say anything? And if anyone else has any other questions,
I would just say that I think the points are that it's a complex everything's so complex. It's a very complex situation and it's always helpful for me to kind of be reminded that these issues don't live in isolation. And I think as a researcher, that's one of the things that, I'm looking at this in this bubble, right? And so what I hear is, well, this is, that there's all these other factors that aren't being taken into consideration, that do need to be taken into consideration. And from my, when I'm trying to approach this, I'm trying to think, okay, there is this one particular, I do know that like I have very, very, very limited expertise and knowledge that I try to get trained up on. And I'm like, okay, well, what I'm saying, I'm not saying that again, that this is not going to be the fix all be all. I am saying that it is one component that I know can be an issue for many people. And if it's not addressed, it's going to be worse than it if it is. Now, it may not work for everybody. And there may be factors that's going to make it not work for certain people. And I think that that's another thing for research, understanding who it works for and who it doesn't. So far, there does seem to be some positive outcomes for some people that go through this training program. For other people, it might not do anything, or more work, or different aspects may need to be may be needed to work on a more holistically or complete way. So I definitely recognize that for sure.
Well, I think that your data does show that it's helpful and it does equip a person. The talk April 23rd is going to be a panel about the mental health problems that come with brain injury. And, it's not even a question if you have a brain injury, if you work around people with brain injury, that happens all the time and it's a big issue. So I think I see this, the building of capacity to deal with your feelings and feel them is beneficial overall, but it's really, really hard. I wanted to send you a podcast, the one I just put out last night. The discussion of PTSD and TBI interacting comes up, but also the interaction of all the internal problems gets explained really well. And I see every brain injury person as having brain injury problems. So that's why we can collectively share about it. The problems are drastically different though. Um,
Hmm.
yeah, and then having the ability to feel and deal with the feelings, if the brain injury problems are constant or remain, because those parts of the brain got injured, then they have the model now are saying brain injury is not an incident, but they're not saying what it is. So brain injury has shifted internal things in each brain injured person. I want to talk to Bill about his cognitive rebuilding because it took me a long time to improve that part of myself, but that's just one of the many examples. So that's why there's a lot of common threads here. But yeah, the emotional part is so unique. I have one last question for you, and then I think maybe we'll be done. But do you think the biopsychosocial model fits alexithymia with brain injury?
What do you mean? Does it actually? I tend to see it very much from a biopsychosocial model. I guess I'm. What can you say more to the
If
question?
emotions, are they biological or are they psychological?
Oh, I think that it's both. I think it could be. I
The
think for every
inability to
person, it's
have
going to
it,
be.
then. Yeah.
What's that? Say
The
again.
inability or not having access to the emotions, it seems to me like it's missing. Bio and psycho doesn't fit when that part isn't there because it's not only captured in bio and psychological. It's like underneath psychology. Emotions allow for psychological to happen. So when it's
But I
injured,
would think of that as the biological. So the biological emotional reaction.
but the biological is the process in the brain, the emotion of the depth of the feeling when you hit that well of sadness or whatever the emotion is. That's separate from a biology. That's an emotional experience. It's a manifestation of the brain and it's underneath the psychology. That I see it as I'm advocating for it to be a different level than either of those.
What would you
Um,
say?
if the brain produces mind or other capacities of the mind and internal self, that when those get injured, the interoception literature is talking about people being aware of all these things. So when those things aren't working, you build an internal awareness of that, and then you have to deal with that every time an emotion happens. Every time, like if you're blind, your eyes wouldn't work. It's not biological or psychological, it's the capacity of vision is gone. So
Hmm.
this is that with emotions. And emotions, when you actually have them, because I do have them now, it's so much more color and so much more depth and so much more pain and so much more just like this ragefulness comes out and then the feelings. I have the rage, sadness, and pain come out in these ways, and those feelings are way harder than biology, and embedded in psychology, but when you don't have them, you're still having psychology happen. It's something else. It's between the B and the P of that model.
I think that there's overlap. Like I think that they can coexist, like that it's coming from both. That it's not just one or the other, and it could that it's some of each and they can influence each other, that it's bidirectional. And maybe
But
it is
vision, right, but vision or movement, you wouldn't say that that's biological or that's psychological. So emotion, especially when you don't have it, and then it comes in, it like fills in the world that's neither biological or psychological, or it's a manifestation of the biology, and it's what makes the psychology happen, but is underneath it. That's how I look at it. I'm repeating.
I need to, so I'm one of those people that takes a while to digest and process. So I'll
Yeah,
probably have more thoughts on that afterwards because it's a deep question.
that's what I think about. Deep questions.
Yes,
Thank
you
you.
do. You do. And everybody on this call had great comments, great questions. Again, it's always in my mind, a bidirectional learning experience, hopefully. Learning
Yeah,
from
that's why
each
I'm
other.
glad that you're here, and I'm glad that we can do this. And I agree. I think everything that people said, I have to listen to it and process it as well. We're gonna end it. Thank you, Don.
Thank
I'll
you,
probably
everybody. It's
Thank
great to
you.
see all of
Thank you very
you.
much.
Thanks for having me.
Thank
thank
you,
you.
Don.
Um,
Thank you.
all right.
Bye.
Thank you.
Bye, everyone.
Bye.
Next. Thanks. Bye.
Bye.
Um, I see that there's another question, and um, Punet, how do you pronounce your name? Do you want to ask a question?
Yeah, I have a small question. Like you are very experienced in the brain injury. So
Yeah.
right now I have like it's been more than 2 years that I suffered a brain injury, and yeah, so my motor functions are still not fine, but I'm able to like recollect everything. My memory, my emotions, everything is fine. Only the motor functions is not fine. I'm not able to stand by myself, and then not able to run. So is it going to like get back? I'm going to get back to normal, or this is the way I have to live
What you're
for
asking is very interesting because it's not on this topic, but I'll answer, and I'm glad to talk to you more about this later. I just put out an autonomic nervous system dysfunction and brain injury talk, and the first question at the end of that talk was another person who described injury to movement and control of his body. And I look at this as brain the brain has many different capacities and functions and things that it controls, and each thing can get injured in its own unique ways. And it sounds like you've injured movement, and I think you need to find a way to work on that. Steve Carnes is a person who had a brainstem tumor removed, and he lost movement, and his inability to have movement is something he was able to rebuild with a process. I'll send you the talk about that. And I think that this is important to talk about because it's another example of a capacity that got injured. If emotions is something your brain can create, movement is something your brain can create also. And there's a whole bunch of other stuff with that. I've done an interview with Moz about all her different brain injury problems. I want to do an interview with Bill about his cognitive restoring through work because I had something similar. And so I don't know the answer, Punet, but I do think that finding a way to get at the movement and work on it is the way to go at it. And I have a few links I'll share with you.